through this talk. This is 2021, 124 to 37. Okay, so what they say, this talk is, believe me, this is really important, and definitely you will get one question from this talk without fail, because this is always a favorite topic. Even you can get more than one. So definitely this talk you have to go through well. Like last time we went through vascular injury and ureteric injury. Definitely in your exam there will be question from that talk. SSI, infection of the superficial or deep skin incision or of an organ or space occurring up to 30 days. So anything within 1 month after surgery. But if you have put an implant, means any foreign body you have put, then it will become up till 1 year. So you have to understand this difference. Till 1 month and up till 1 year with implant, any infection will be SSI. The incidence, if you see, up till 6%. Rates following CS, very important. Rate following CS will vary. If you see, wide range from 3 to 15%. So in exam, they might give you up to 5%, 10%, 15%. So you will choose up till 15% in cases of CS, because different places, different percentage they got. Following abdominal hysterectomy, again, they have written a wide, full paragraph about different incidences that in this country, in US, it is 2.7. Earlier, it was 1.6. Now it is this, now that. Then finally, they have given that the recent study says that following hysterectomy, it is up till 1.9%. So just remember vaguely like 2%. 2% risk after hysterectomy. But if you see CS, it is quite high, up till 15%. So just keep it in mind. Now, most common causative organism, that is also their favorite question, always they ask about organism. So most common is enterobacterials, means E. coli. Usually in our, like UTI, we say E. coli is common. The same way they say that for wound infection also, E. coli is more common. Most common causative pathogen is enterobacterials, also previously known as Enterobacteriaceae, the same E. coli. Now, enterobacterial and S. aureus, if you see, enterobacterial is 30% and S. aureus is 22%. 22.9 means almost 23%. So, so you see that S. aureus is lesser than enterobacterial. But if you see after CS, S. aureus is more common. So you have to understand all over for SSI, for any procedure infection, the risk is mostly by enterobacterials. But if they ask you for CS, you will choose F. aureus. For any skin infection like CS, like breast infection or whatsoever, whenever it is skin infection or episiotomy infection, any skin infection, usually we think about S. aureus. But you have to understand that for any SSI, they say that most common is enterobacterial. So either they will ask you this, or they will ask you what is most common SSI after CS. So both ways you have to remember that this is most common, but S. aureus is most common for CS. So these are all incidences as well as the organism. Now, risk factor, if you see risk factor are same like we understand for any infection, like if she is obese, diabetes, smoker. Smoker means their vascularity is less. Immunosuppressed, poor nutrition is very important point usually we ignore. Length of stay in hospital, anemia we know. Pre-operative, if you see any complication like previous cesarean, multiple, all these things, hair removal, all this, whatever you can understand. This you don't have to buy hard. You can understand this in options. Intraoperative means again, if you have done rupture of membrane, prolonged vaginal examination, prolonged labor, emergency, chorioamnionitis, all these things. Surgical technique, if it is poor, if you have put drain, you have not used antibiotic, if there is PPH, if there is pyrexia, all these things. Post-operative, if there is blood collection like hematoma, if blood transfusion, if again she stayed long in the hospital. So all these things by seeing you can understand. So just go through it once to understand that you are, maybe you are not able to understand 1 or 2 points, you can try to understand that. Now, CS antibiotic prophylaxis. All of you, my dear, all of you, you should remember this, because CS antibiotic prophylaxis is always their favorite. So you cannot afford to miss even a single point from this. If you see how much it will reduce the rate of infection, SSI rate, if you see by giving antibiotic, then it reduces up till 60 to 70%. 61% reduction in wound infection, 62% reduction in endometritis, and 69% serious maternal infection. All in all, somewhere between 60 to 70. If they ask you how much wound infection, you will choose 60. If they ask you how much endometritis, it is 62. If you see after CS, most common infection, it is endometritis. So it is significantly decreasing it by 62%. So that's why it is important. The 60% is really, really important. If you see the rate of elective and emergency CS with or without antibiotic, if you see, with antibiotic, it is only 68, while without antibiotic, it is almost 100. If you see, it is almost 100 per thousand and 70. So quite a significant decrease is happening. That's why they say that you have to use prophylactic antibiotic with CS because it will reduce your infection by 60%, 60 to 70% overall. Now, we saw it will reduce by 60 to 70%. The US guidelines say that first generation within 60 minutes, but NICE says at the time of anesthesia. Augmentin you will not give before cord clamping because augmentin, if it goes to the baby, it will cause necrotizing enterocolitis. That's why augmentin you will not give before cord clamping. So after cord clamping, you can choose augmentin if you want to. But before cord clamping, no, because it is dangerous for the baby. Now, this is the table, very, very, very important. And definitely the question is from this table. If you see in cesarean hysterectomy both, if you see there is either first or second generation cephalosporin plus metronidazole. Here also same, here also same. Only difference is coamoxiclav because you cannot give coamoxiclav in patient with CS because it will lead to necrotizing enterocolitis. So please remember this. Please, 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 because there is no excuse for this. This is the most common question. Now they will ask you, sometimes they will give you in question that she's penicillin allergic. So what you will give? So this also become important. You will give Clinda plus Genta. So this also you have to memorize. Again, here also same. So these all are almost same. Only difference is by CS, in CS, you cannot give her coamoxiclav. Am I clear about this fact? Clear, my dear? Or not?
Yes.
Okay, good. Now, perineal procedure. You know, always when we used to read the guideline of third, fourth degree perineal tear, I always used to think that what antibiotic we will give. But we had no clue at that time because they have not mentioned in the guideline. But now at least they have come up with when you are doing perineal procedure, you have to give coamoxiclav 1.2 grams start followed by coamoxiclav 625 8 hourly for 5 days. So now you have a clear cut value. Coamoxiclav start followed by for 5 days. Or you can give cephalosporin metronidazole start followed by coamoxiclav for 5 days. So both ways, now you at least you have a fixed antibiotic for perineal repair, third degree, fourth degree perineal tear. You will give this. Can I ask you, is operative vaginal delivery need antibiotic, prophylactic antibiotic? Anyone?
Yes.
No, I think no.
Yes.
Yes. Yes.
Yes, it needed because the new guideline earlier it was saying that it doesn't need, but now the new guideline of operative vaginal delivery say that it is needed. So what antibiotic you will give, my dear?
Coamoxiclav.
Very good. But this is also the last exam question that in AVB, in assisted vaginal birth, which antibiotic you will give? So the answer is coamoxiclav single dose. You will not continue it because it is prophylaxis. While in perineal procedure, you give it up till 5 days, like third and fourth degree tear. So please remember this. Now in MROP, manual removal of placenta, will you give prophylactic antibiotic or not? You will give. Okay. Manual removal also, you will give 1 dose of prophylactic antibiotic, but after removal, it will depends on the sign and symptoms. You will not continue it until unless there is any signs of infection like fever or anything. But a loading prophylactic dose you will give. So manual removal of placenta, whenever you are doing, you will catheterize the patient because there could be blood loss, she may go in shock or something. So catheterization is must, and as well as empty bladder help in placental separation. So that way, catheterization as well as one dose of prophylactic antibiotic is what you have to give. The same for operative delivery, you are giving one dose prophylaxis, which is coamoxiclav. So don't get confused. Coamoxiclav, and coamoxiclav everywhere except in CS where you can give after cord clamping, not before. So please remember this well. Now, if MRSA positive patient, what you will give? You will give teicoplanin, either teicoplanin or vancomycin. These are the drug for MRSA. These all antibiotic of MRSA and all these things we will be revising in the sepsis guideline. So don't worry about MRSA, but these things are really a boon. Because earlier we used to search in NHS site here and there, local hospital protocol, but thankfully they have given it in TOG now. So we know what to write in the exam. So penicillin allergy, very important, Clindagenta, and all these things are really important. Now, hysterectomy. What is the chance? How much, like in CS, we saw that prophylactic antibiotic will decrease it by 60 to 70%. Now, how much in hysterectomy it will decrease? So in hysterectomy, it will decrease from 16% to 1 to 6%. So very important, very significant decrease. The same for vaginal, the same for abdominal. So this is the decrease. Now, cefuroxime, for example, because we are giving that is second generation, it has a half-life of 1 to 2 hours, as I told you, up till 90 minutes, right? They say that you may give within 60 minutes of the incision. Now, if there is prolonged surgery, there will be higher risk of SSI. If you see, if the surgery is less than 1 hour, it is only 6%. While if it is more than 2 hours, it becomes 28%. So you're seeing how much significantly it is rising. From almost 4 to 5 times it has increased if it is lasting more than 2 hours. So definitely you need to repeat the dose. That's why they have told that redosing is required if surgery is more than 3 hours or blood loss is more than 1.5 liter. Very important. Clear all of you? This is really important for SBA, that when you will redose. Okay, now some important facts about this talk. They have told that what about the prophylaxis not recommended in which procedures, what are the special cases, what you will do with obese women. These all are important points because they might ask you in the exam that you got a woman who is 21, 23 kg. So will you give her the same prophylactic dose or will you give her the more dose, or they will just give you the option that you will give cefuroxime or cefazolin 1 gram, 2 gram, 3 gram, 4 gram, like that. So you have to understand that in morbidly obese women, you have to give a bigger dose. So whoever is weighing more than 120 kg, you will give 3 gram in place of 2 gram. So this could be a tricky SBA for you. So you have to remember it, that the risk is higher, so the dose also should be higher according to her body weight. So in place of 2, you will give 3 kg for more than 120 kg. While if the woman has cardiac condition, thoracic transplant, all these cases, the surgical prophylaxis will be same as for any other routine patient. When the prophylaxis is not recommended, we already saw clean, non-prosthetic, uncomplicated surgeries. Other than that, you have to understand endoscopic surgeries. What are the endoscopic surgery where you don't have to give the prophylaxis? You don't have to give for hysteroscopy. You don't have to give for diagnostic lab because it is just hardly 10 to 15 minutes job. So diagnostic laparoscopy is just putting the laparoscope, seeing and coming out. So it doesn't take much of a time. Laparoscopic sterilization, it just takes 5 to 10 minutes. Sterilization, just you enter, put the clips and come out. It's really ring or clip or whatsoever. So it is really a small procedure and it is done endoscopically. You are not opening the women through and through. So just you have made a hole to enter your instrument. So that's why they say that risk of infection is really less. That's why no need of prophylaxis in such surgery. This is a very common questions in exam, that when you will give, when you will not give. So you should have a clarity about antibiotic, when to give, when not to give. If you are doing ovarian cystectomy for uncomplicated simple cysts like lap ovarian cystectomy, simple cyst, you will finish within 15 to 30 minutes. So it doesn't take longer and it is an endoscopic surgery. all these laparoscopic procedure, you don't have to give any prophylaxis. Please remember this, because they might make an SBA saying these three and one fourth, which fourth one require the prophylaxis, and these three doesn't require a prophylaxis. Am I clear about this point? This slide is really, really important and tricky, because this is contradictory statements, what we think, and this is something else. So we have to memorize it and understand it, that in TOG it is clearly given when not to give. Clear, all of you? My dear, please, if it is clear, say it clear. If it is not clear, say it not clear. So at least we will go forward. Otherwise, I will just sit and wait for your yes or no or whatsoever. So please message. When I ask you clear, if it is clear, just type a Y is enough for me. Okay. Treatment CS wound infection. Now we have seen till now the prophylaxis, when you will give, when you will not give, what you will give, and how it will decrease the risk. Now, treatment. So definitely if you have done prophylaxis, there could be still infection. So what you will do, you will treat it. So what will be your first line? Again, coamoxiclav. Because now there is no fear to the baby. So your first line will be coamoxiclav, because as we saw for CS, the most common organism is Staph aureus. So coamoxiclav is the first line antibiotic. Typically, if you see, this will develop within 4 to 7 days post-operatively. So women, you will discharge her home after CS after 3 days. And after that, she'll come to your ER with wound infection within a week. So you have to remember like that, that is the most common period. Typically, it present at that time. Any fever more than 38 degrees in two occasions, at least 4 hours apart, more than 24 hours after surgery, because the first 24 hours, it could be reactionary high fever, the tissue reaction. So that's why first 24-hour fever, nobody consider it significant. But after 24 hours, if you get more than 38 degrees 2 times, then you will take it as infection. First line, coamoxiclav. If she's allergic to penicillin, then you have to see that how severe is the allergy. If there is no severe allergy, you will go for cephalosporin metronidazole. But if there is severe allergy means like breathing difficulty and all that thing. So in that case, you will not use cephalosporin also, because sometimes there is cross sensitivity between cephalosporin and penicillin. So they say that always in absence of severe allergy, you can use. But if there is severe allergy like choking and all that, then you have to use Clinda or Vanco. Whenever there is penicillin allergy, you are seeing constantly that they are using Clinda. Clinda is a alternative for penicillin. Am I clear about these facts? And the other important point is the Genta. When to add Genta? Means if the patient, you have given all these things, but still she's febrile after 1 or 2 days, usually you wait 1 or 2 days for antibiotic to act. If after 1 or 2 days still she's febrile, means the organism is something different and your empirical antibiotic is not working. In that case, you always have to add Genta. Then Genta is for the gram negative usually, and renal function you have to assess before giving the Genta. So this is very important point sequence wise, that first you will give coamoxiclav. If not working for in 1 or 2 days, then you have to add the Genta. Am I clear about all these choices of antibiotic? Very good. So following hysterectomy, if you see again coamoxiclav. Hysterectomy, after hysterectomy, usually you will see vaginal cuff, pelvic cellulitis, pelvic abscesses, anything. If you see any purulent discharge, anything, you will treat by coamoxiclav. So if in exam they give you infection, then you always have to choose coamoxiclav for hysterectomy and CS wound. But if there is superficial incisional SSI, means if SSI is on only on the wound, superficial, then in that case, you will give a flucloxacillin, which is also a drug of choice for which condition? Flucloxacillin is drug of choice for what else?
Mastitis, like.
Yes, very good. So mastitis also flucloxacillin. The same way superficial incisional SSI, you can use flucloxacillin because it is a simpler one rather than coamoxiclav. which is a broad spectrum. So these all antibiotic choices very important. Now we have to differentiate what is deep-seated infection and what is necrotizing fasciitis. So deep-seated infection means not only on the skin, but it is going little deep. So it could be pelvic cellulitis, vaginal cuff infection, parametrial infection, abscesses, or anything. Definitely, you have to give the antibiotic, but you may need surgical exploration. You may have to drain the abscess, you may have to wash it, irrigate it, insert the drain. All that thing might be needed. For deep-seated infection, you'll start antibiotic and you will consider surgical exploration according to the patient's situation. Other important aspect is necrotizing fasciitis, which is always favorite of RCOG. What is it? Necrotizing fasciitis, when they want to give you in exam, they give you like pain out of proportion. Means pain is not relieving with analgesic. It is showing vesicles, crepitus, edema, cellulitis which is not responding to antibiotic, pain which is not responding to painkillers. So something deep is going on which we are not understanding and able to see from outside. So in that condition, and as it is rapidly progressive, so your mainstay of treatment will be antibiotic and surgery. So you will not may need, you will definitely need. And in this situation, it's clearly given in RCOG that you have to take plastic surgeon opinion. So plastic surgery referral you will always give if you are suspecting necrotizing fasciitis. Because it could be real bad, and sometimes there will be deficient of skin and all that. So you have to involve the plastic surgery team. What antibiotic you will give? Again, penicillin. You have to give a penicillin. Then one aminoglycoside you have to give if our renal function is normal. So penicillin, Genta, and Clinda. When you see in the sepsis guideline later, we will cover it. Genta and Clinda are always an important part. So Genta and Clinda and penicillin. These three things you have to give for necrotizing fasciitis and surgical debridement for sure. So in the option, never choose only antibiotic or only surgery. Both combination you will choose. Here in deep-seated infection, you have to think about surgery. In superficial infection, only antibiotic will be enough.